Maintenant, nous allons passer à la communication suivante et un petit changement, non pas des orateurs, mais du contenu. Professor Felix Mahfoud from Hamburg, Germany, and the subject is what's new in interventional cardiology. Okay, it's perfect.
Thank you very much, and good morning. So we recognized yesterday while browsing the program that we had a topic on heart failure, but nothing on interventional cardiology. So that is why Atul and I decided late yesterday that we changed the topic. So Atul Pathak will talk later during this session about what is new in heart failure, and I will discuss with you what is new in interventional cardiology, and will primarily focus on trials that were presented at ESC and TCT, so the big two congresses in cardiology very recently, and that have been published. So let's start with acute coronary syndrome. I picked 4 studies that I think are important for clinical practice and may or may not change guidelines in the near future. So let's start with the relief of hypoxemia. The NZOTEX trial is a study that investigated supply of oxygen in patients with acute coronary syndrome. And you may know that there was a study from Sweden published 2 years ago where they showed that it is indeed deleterious to patients if you supply oxygen without a demand. So in patients where the saturation is above 90, we should not supply oxygen. And this is a new study now where they investigated in a large cohort of patients, 41,000 patients with suspected or confirmed acute coronary syndrome, in a cluster randomized fashion, so dedicated sites were randomized to a protocol where they supplied oxygen to all or supplied oxygen only to patients where the saturation was below 90%. You can see that it was 1-to-1, almost 1-to-1. Low oxygen protocol means oxygen only provided to patients with saturation below 90, and on the right-hand side here in purple you can see the high oxygen protocol, 20,000 patients that received 6 to 8 liters of oxygen per minute in patients with acute coronary syndrome. And this is the primary endpoint, death at 30 days, absolutely no difference. So another trial confirming indeed that even when you look at it adjusted or unadjusted, the supply of oxygen in patients with acute coronary syndrome without a demand, meaning with a saturation above 90, is not beneficial for patients and should not be performed at all. 3 studies that are important on antiplatelet therapy, ISA REACT 5, Popular Age, and Popular Genetics. I think most of them will have impact for the guidelines that will be released next year about antithrombotic therapy. So you may know that we have a class 1B recommendation for ticagrelor, 180 milligrams as a loading dose, and then 90 milligrams twice a day for patients with acute coronary syndrome. And we also have a 1B recommendation for patients with acute coronary syndrome undergoing PCI for prasugrel, 60 milligrams of a loading dose, and then 10 milligrams daily on top of aspirin. So these 2 agents are accepted, P2Y12 inhibitors, and should be given to patients with acute coronary syndrome. And there was an ongoing debate whether or not the one is better than the other. We haven't had any evidence where in a head-to-head study these 2 compounds were compared, and this is the first one, ISA REACT from Munich in Germany, 4,000 patients with invasively confirmed acute coronary syndrome. You can see that 40% of the patients had STEMI, 46% NSTEMI, and 13% had unstable angina. Patients were randomized then in an open-label fashion to prasugrel or ticagrelor. As said, prasugrel 10 milligrams once daily and ticagrelor 90 milligrams twice daily. You can see that they also had different administrations that were compared. The loading dose for prasugrel was given after coronary angiography in NSTEMI patients and at randomization in STEMI patients, and for ticagrelor patients the loading dose for all patients was given at randomization. The study, and that is interesting, was powered to show superiority of ticagrelor, so the investigators thought that ticagrelor is the better P2Y12 inhibitor, and it was quite surprising to see that the opposite was found. This is the primary endpoint, death, myocardial infarction or stroke at 12 months. In the intention to treat analysis, you can nicely see that prasugrel was better than ticagrelor. The hazard ratio was 1.4, meaning that you have a 40% reduction in risk when you have patients on prasugrel instead of ticagrelor. That was highly significant. The p-value is provided here and provides evidence indeed that not only, which is nice to see, that the primary endpoint of ischemic complications was reduced. There was also no significant difference in bleeding, so we're not paying a higher price of bleeding complications when we prescribe prasugrel to patients with acute coronary syndrome. An important trial, I guess. More will become. There's some criticism around this study because some of the patients in the prasugrel arm were lost to follow-up. So there's an ongoing debate now with the investigators whether or not that had an impact on the study. But anyway, I think it's important. It provides further evidence for the use of prasugrel in patients with acute coronary syndrome. A problem with these very effective antiplatelet agents is that in the studies that were used in the past, actually, that provided approval of these drugs, a high number of patients older age were excluded from the trial. So for ticagrelor, for instance, the trial limited inclusion to 75 years of age. So it was important to understand whether or not in older patients it may be different when we prescribe drugs. Clopidogrel versus ticagrelor or prasugrel was tested here in patients with NSTEMI in patients of 70 years of age. 1,000 patients were enrolled, randomized 1-to-1. And you can nicely see, interestingly, the study was powered for non-inferiority, which is also provided here. You can see on the right-hand side that there were less major or minor bleedings at 12 months in patients when we prescribed clopidogrel compared to ticagrelor or prasugrel, again in patients older than 70 years of age. Popular genetics, an interesting study for many reasons. It's the first study where a genetic testing was performed in the cath lab, and the colleagues changed their prescription regimen according to the genetic analysis. So what they were looking at is the following. There's a dedicated SNP, a dedicated polymorphism that makes you a non-responder to clopidogrel. And what they did here is they did the genetic testing in patients, 2,500 patients with STEMI that underwent primary PCI. And according to the genetic testing, they looked into the SNP. If you had the polymorphism, if you were a non-responder to clopidogrel, you were prescribed prasugrel or ticagrelor. If you were not a non-responder, so if you were responding to clopidogrel, you received clopidogrel, and on the other side you can see the non-genetic testing. So that is what we would do anyway, prescribing prasugrel or ticagrelor for at least 12 months in these patients, which was considered the control arm. And this is the first study that confirmed non-inferiority of this genetic testing. You can see here on the right-hand side all-cause deaths, recurrent myocardial infarction, definite stent thrombosis, stroke, and major bleeding. The blue line is the standard therapy, and genotype-guided therapy significantly lower for non-inferiority. It didn't hit the superiority margin, so it wasn't better than standard therapy, but it's the first trial, indeed, where in the cath lab we used genetic profiling to guide our therapy, and I think it's an interesting one, which was very recently published in the New England Journal. What about bleeding? And this was then an interesting finding. So if you select your treatment strategy according to a genotype of a patient, you can significantly lower bleeding complications. That is shown here. For standard therapy, 12.5%, so almost a 3% absolute reduction, 30% relative risk reduction for bleeding in patients that were prescribed a genotype-guided therapy. So in summary, for acute coronary syndrome, we had the ENZOTEX trial showing that we should not supply routinely oxygen therapy for patients with suspected acute coronary syndrome who do not have hypoxemia. ISA-REACT-5 showed superior outcome for prasugrel compared to ticagrelor in patients with acute coronary syndrome. Popular age, Less bleeding with clopidogrel trial specifically focusing on elderly patients. I think that is for routine practice very important. And Popular Genetic is the first one that used genetic testing in the cath lab and showed non-inferiority to standard therapy with prasugrel or ticagrelor in STEMI and reduced bleeding. What about revascularization? What is new in interventional cardiology and revascularization strategies? I picked 3 trials that were presented and published very recently: Syntax, 10 years follow-up, Complete, and ERIC PPCI. Elective and acute revascularization. What is new here? The Syntax trial, you all know, compared patients with coronary artery disease, severe coronary artery disease, left main or 3-vessel disease. And it was the first trial where the first generation DES, Taxus, was compared to Gabbage in patients with multivessel coronary artery disease and left main stem. And here you can see the 5-year follow-up where patients had no significant difference in 5-year mortality between PCI and Gabbage. So this is a so-called landmark analysis. The first outcome at 12 months showed superiority of Gabbage over PCI, but over time this appears to be leveled out. This is 5-year, and at ESC the 10-year data has been presented. You can see that 1,800 patients were included in this study. We have 10-year follow-up available for 840 patients, so 93% in the PCI group and 95% in the Gabbage group. On the right-hand side, the landmark analysis for 5 years of follow-up, mortality, no significant difference, and landmark analysis 5 to 10 years. The curves are superimposed, indicating that there was no significant difference between the 2 treatment strategies, even after 5 to 10 years of follow-up. Any specific subgroup that did better or worse? This is left main, an important cohort of patients, because we are more and more treating these patients interventionally. They are not routinely referred for Gabbage surgery. And you can nicely see that left main, even irrespective of the Syntax score, superimposed curves, so no difference in outcome, indicating that we may indeed do PCI or Gabbage in these patients with comparable outcomes. 3-vessel disease, that's important. If you see patients with severe 3-vessel disease, they tend to do better after Gabbage compared to PCI. The hazard ratio here was 1.4, significant, again indicating that Gabbage for patients with 3-vessel disease may be better than PCI. This is related to the Syntax score, so to the complexity of the underlying anatomy. The more complex the coronary artery disease is, the better Gabbage is doing, and you can see that it appears to get significant after Syntax score with more than 33, as shown here for the hazard ratio, which was significant only for patients with Syntax score of 33 or more. Diabetes, and we are fighting and discussing this all time with our heart surgeons. Diabetes primarily is not an indication for Gabbage surgery. You may have patients with severe coronary artery disease, 3-vessel disease, that do better, but diabetic itself is not an indication for Gabbage surgery. So left main in a diabetic patient does not automatically mean that patient has to undergo Gabbage surgery. Could be PCI also, which is shown here. No difference for diabetes versus no diabetes at long-term follow-up. Multi-vessel strategy and ischemic preconditioning, the last 2 studies I wanted to share with you. Complete was a study where different strategies were compared. We do see patients who undergo primary PCI of the culprit lesion for STEMI, and in many of these patients we see other stenosis that are significant too. And in this trial, if the patient had 1 or more angiographically significant non-culprit lesion, he was or she was included, and it was uncertain whether this should be done in the same session, so routinely revascularize them with PCI, or manage them conservatively with guideline-directed medical therapy. That was the question. And it was a trial that was powered to show cardiovascular death and myocardial infarction, 2,000 patients in each arm, again randomized and stratified to in-hospital or after discharge. revascularization, and you can see that the complete patients here, indicated as the blue line, did better for the co-primary outcome of cardiovascular death and new myocardial infarction, and the second co-primary outcome, cardiovascular death, myocardial infarction, significantly better for the complete strategy than for the culprit lesion. That's important for us doing interventions in the cath lab, so we changed actually our strategy, and we are completely revascularizing patients now with all culprit lesions. I go through this very quickly. The timing of the lesion during and after initial hospital stay. You can see that most of the patients were treated within 1 day, and after discharge within 23 days. And again, as said, this improves outcome. And lastly, ischemic preconditioning. You have heard about the concept, I guess, which is quite an old concept. So the reperfusion injury contributes to the infarct size in STEMI patients, and the question was, if you perform remote ischemic preconditioning, for instance, during ambulance transportation, as shown here on the right-hand side in STEMI patients, there was a paper published in The Lancet a couple of years ago. The idea is to reduce the infarct size, and there was a large trial conducted to finally answer whether or not remote ischemic preconditioning is beneficial to patients, randomized to control, or RIC, 5,400 patients, and I make it short. These are the curves, absolutely superimposed, nothing really behind it. You can even zoom in and see whether there is something, and there is nothing. So remote preconditioning, I think we can close that book and concentrate on other things. Here, it had absolutely no impact on patients with acute coronary syndrome for 12 months. Again, absolutely no effects on cardiovascular death and hospitalization for heart failure. What does that mean for interventional cardiology? I think we have now data that we can perform CABG or PCI in patients with coronary multivessel disease and patients with left main. We have evidence approach to answer relevant questions about staged multivessel PCI, which is superior to culprit only in STEMI, and remote ischemic preconditioning does not provide a measurable benefit in STEMI patients undergoing primary PCI. Thank you very much for your attention.
Thank you very much, Felix. Is there any question? No? So for you, what is the most important data from interventional cardiology from 2019? What is it? Is it the genetic aspects, etc.?
I think what was important was ISA-REACT, because we very often are challenged by the question, which antiplatelet should I prescribe to which patient? So I think that the data provided here, prasugrel superior to ticagrelor, is important because we're doing that every day in patients. But I also liked the study where they looked into older patients, so it's meaning 70 years of age and older, where clopidogrel was non-inferior to prasugrel and ticagrelor. So this is, nicely showing that we have to individualize our therapies according to age, according to risk, and probably, and you mentioned it, according to genetics. But this is, not something we can do tomorrow, because the genetic testing in this trial was done online. So they took a blood sample and they performed the genetic testing, and they got it within hours, which is in many instances just impossible because of the resources. We can't do it at our university. There's more to come, but I guess the genetic profiling and the individualized, the personalized approach is becoming more and more important.
And how long to have the results of the clinic, the genetic aspect during the angioplasty? How many time to have the results of the genetics?
So they received the genetic phenotype in all patients that were randomized to the genetic guided therapy, and it took them on average 4 hours to get the result. So it was really quick, really amazingly quick.
Pas d'autres questions? Bien, merci. Merci.
Thank you very much.